Good morning. My name is Susan Sims Marsh. I am president of the AKA Foundation of Central Pennsylvania and a proud member of Alpha Kappa Alpha Sorority Incorporated, Epsilon Sigma Omega chapter. Can you believe it? This is our fourth It's About You Community Health and Wellness Expo. Now let me just get a few points of clarification. For those of you who are lucky enough to be the first 50 and you had that little card, this presentation counts for that. But you must stay until the end. And then there will be people on either side that will punch a hole in your little reward card. And if you haven't finished circling to the exhibits, you can do that, and then you can turn your card in at the registration desk on the opposite side with the pink tablecloth to receive your $50 giant gift card. Does that sound good? So we are so happy. Some of you are repeaters, and so we appreciate you. We truly appreciate you coming out each year for the expo. Now, I'm telling you now, you can put it on your calendar. For the next 5 years, it will be at this location on the second Saturday in October. And we will always have first 50 people who make their way around to 10 locations, including the Ask the Doctors panel. You'll receive that $50 gift card. But I'm sure that's not the only reason that you're here with us this morning. So before I turn it over to Dr. Siobhan, I want to share with you for a few moments, President of Alpha Kappa Alpha Sorority Incorporated, Epsilon Sigma Omega chapter here in Harrisburg. Gladys.
Good morning, good morning, good morning, everyone. It's so great to see all of you here. My name's Gladys Brown Dutrell. I am the president of Epsilon Sigma Omega chapter here in Harrisburg of Alpha Kappa Alpha Sorority Incorporated. We are so glad to be also partnering with the AKA Foundation of Central Pennsylvania on this great event. Every year it gets bigger and bigger, and we're just so happy to have all of you here. And at this point, we will turn it over to Dr. Siobhan, who's going to be our moderator. Thank you.
Good morning. Good morning. All right, let's do it one more time. Good morning. Good morning. There we go. There we go. Before I start, I have some index cards, and if sometimes people get a little shy about asking questions directly to us, if you would like an index card and you want to write your question on an index card, just put your hand up. I will come around and pass you out an index card, and then I will also come and grab your index card. Would you like a card? Oh, okay, I thought somebody else. Yes. And I will also come and grab your card to ask the questions too. So again, thank you all for coming this morning. And I am joined by 3 wonderful colleagues. I'm actually going to let them introduce themselves. And so I'm going to start with Dr. Screen.
Good morning. I'm happy to be here. I am Dr. Robin Screen. I am the Director for Breast Surgery for Geisinger Health Systems based out of Danville.
Good morning. Can you hear me? Okay. Good morning. I am Dr. Margaret Peoples-Marsh, and I am a clinical pharmacist. I've worked, can you hear me? Okay. Oh. Okay, let's try this again. Good morning. I am Dr. Margaret Peoples-Marsh, and I am a pharmacist. I have worked hospital, retail, clinical, industry. I've taught, so I've done a little bit of all aspects of pharmacy, and I'm here to hopefully arm you with questions and things that you may need, may be helpful to you when you go and visit one of these two.
Good morning. Good morning. I've been here before. You know me from before. I'm Carlos Cream, internal medicine. Previously, I was with UPMC. Now I'm proud to say I'm with Hamilton Health. I see many of my board members here, members of our team here. It's always a wonderful event, and I look forward to an engaging conversation again like we always have.
Testing. 1, 2.
And I just wanted to introduce myself real
Testing.
quickly. I am Dr. Siobhan Momon-Nelson. I am an OBGYN at UPMC Carlisle. I'm currently the chair of the department, and I hold other administrative hats too. So for all the women questions, I will also be answering those questions too. So first, what I want to do is, because I want to break the ice just a little easily, I'm going to ask, are there any questions from the floor for my colleagues? Okay. You have a question for Dr. Cream? Hold on one second.
Good morning.
Good morning.
My doctor just switched over to Hamilton Health Center. She's at the Hamilton Health Center in Newport, Sherry Denenberg. What's your specialty?
Internal medicine.
Okay, she's internal medicine as well.
Yes.
I wanted to know what's your specialty. Are you in Harrisburg or where are you?
I'm located at Harrisburg, yes. I'm the chief medical officer, so I'll be overseeing all of the sites.
Okay, thank you. That's good to know. Because I'm from Harrisburg too, driving up to Newport.
Oh. Understood.
So I'm going to break the ice and ask my colleagues, because it is 2024. However, there's this viral thing that we were going through for the last couple years called COVID. And I think it has really impacted many of our lives significantly. It's impacted our economy and so forth like that. And still in 2024, I still think there is a lot of uncertainty about the virus, about being vaccinated and so forth like that. And so I'm going to start with Dr. Cream and just ask, with regards to being vaccinated, what are you seeing? Are you seeing people that are not vaccinated about the virus? Are you seeing people that are actually still coming in, being sick? Dr. Marsh, you want to talk about the vaccine itself. Is it safe? Is it not safe? Do we need to get a booster? Do we not need to get a booster? And even our patients that are immunocompromised, and so I'm going to ask Dr. Screen to talk about that too. So I'm going to pass it back to the panel.
So yes, the virus will continue to circulate. We are coming into high viral season again now, as we do every year. And again, you'll be hearing more, and I will defer as we talk about more of the vaccines that you're going to hear about. But you're going to hear about COVID, flu, and RSV now as well. And so as you're hearing about the three of these things, when you're getting ill, the weaker you are prior to the illness, the more severe it will be and the higher risk you personally have. This is why we always advocate those who are at the greatest risk for severe disease to be vigilant and to show up early so that we can intervene. Ideally, you have had the vaccination or the boosters if necessary, because they will offer you some immunity. The thing you always keep in mind is that the virus is constantly changing. And so we're trying to keep up with your immunity so that we don't have a large outbreak, epidemic like we did last time because of so little immunity in the community. We get lax because people aren't dying at the rate they were dying at before. People still do die of this disease. And if you are at higher risk, and I'll let others talk about this, you want to be vigilant and make sure you're taking care of yourself. And if not for yourself, for those who you are close to.
Okay, just to piggyback on that, he's right. The virus changes each time. And that's just what viruses do. They become resistant. So once they become resistant, the scientists have to come up with a new vaccine that will overcome that resistance that the prior vaccine will no longer cover. And as was stated before, if you're immunocompromised, hypertension, diabetes, if you have had breast cancer, any kind of cancers, if your immune system is weakened, you need to get the vaccine. It is safe to get the flu shot and the COVID shot at the same time. You can do the same arm. No need to have both arms sore. And most people experience just minor kind of side effects, maybe a little headache, you run just a little fever, feel tired, but that only lasts for about 24 to 48 hours. And then you start to feel much better. So it is highly recommended that you do get both the flu shot and the COVID shot. It's getting cold. We're going to be inside. We sneeze, we cough, we touch each other, and we just make the environment very conducive for viruses to grow and for us to get something.
Can you hear me? Sorry. I echo that sentiment about getting the vaccine. I think what I'm seeing with COVID is a lot of people think it's no longer a threat, and I'm still seeing people who get really sick. And there's always the issue, we worry about dying, but there's always that issue of long COVID. So if you can, it's from the cancer standpoint, I encourage my patients to get the vaccine prior to their surgery, since I usually see them at diagnosis. And as long as it's at least 2 weeks before the surgery, it's usually not an issue. The other thing is a healthy lifestyle, which is your breast cancer risk, reduces your risk of breast cancer recurrence, also helps in fighting COVID.
I just wanted to chime in as an OBGYN. Of course, I take care of young, healthy women of reproductive age, and all of those vaccines are safe prior to getting pregnant, while you are pregnant, postpartum, breastfeeding, and so forth. Those are all things I recommend. Flu vaccine, COVID vaccine. We also vaccinate against Tdap, and we also vaccinate against RSV for those women. I also encourage my mature women to be vaccinated too, especially because there are often times when they see me that they might need surgery, and so I do not want them to be sick prior to having surgery. So I have a question over here.
Could you expound a little bit on the RSV vaccine?
Expound a little bit about RSV vaccine.
Did you want to speak? So RSV is a virus, respiratory syncytial virus. It's one of the things that until COVID, we never really worried about it as much because it's been around forever. And so what happened was children would pass this year to year. This is one of the common variants that we would get. What happens was when we became isolated for so long because of COVID, we all lost immunity because of these viruses constantly shifting. So that when we were reintroduced to it, it was reintroduced as a more virulent strain because we hadn't kept up with our natural occurring immunity from seeing it from year to year. So the people who are most at risk for it now, the vaccine is for people who are 65 or older and have a comorbid disease, or 75 without a comorbid disease. And so the idea, again, is when you're presenting, you're going to present just like you have COVID or the flu, but the third thing, big thing you'll hear about is the RSV. And that's what you'll be thinking about and you're hearing about, for the same reason that when you get sick the first 3 days, you're not going to know which one it is. And you're going to say, am I going to get COVID or not? And if you're vaccinated against these variants, you'll know the likelihood of a severe disease from any of them is lessened. And that's what we're trying to do, is get the most vulnerable people treated early.
I recently had my COVID shot in September, the new variant of the COVID shot. Did I have it too soon, or should I have waited?
No.
Okay. Thank you.
They don't update them that frequently that you'd be out of the window of where it would happen. The more of the issue is when you hear about people getting a flu shot too early, because you worry about it waning towards the end of the season, but getting it and making sure you have it on board is the critical thing.
I did get some questions, and so one of the questions that I'm gonna start with is, how do you advocate for your spouse with their doctor? And I think a lot of us, often have experiences where we go as a support person, and we might not feel that the physician or the healthcare provider is really hearing our family member. So how do you recommend that we advocate for our loved ones?
This is something I preach frequently to my patients about, and something that I think is currently a problem in today's healthcare environment. I think the first part of it is that person you want to advocate for, you need to communicate with them and make sure that's what they want as well. Sometimes we do have another person's best interest at heart, but if we're not on the same page, it doesn't really matter. But when they want you to advocate for them, increase your knowledge, write down a question, and then have to be willing to kick up a little dust. You ask your questions, they're not being answered, you pursue it. You don't have to be rude, you don't have to be nasty, but you can be firm and direct and say, this is what we need to know to help find this out. And I always tell people, if the physician or the healthcare provider is not listening to you, find another one.
And so I will echo that completely. So one of the reasons I'm in the job I'm in now versus before is just for this reason. And so one of the things I encourage everybody to do when they get a chance is go to the website rwjf.org. And then I want you to look up your zip code and the life expectancy of your zip code versus your county and versus the state. You'll be surprised by what you find. So the advocacy portion of it is something that you have to keep pushing, and you have to keep asking the questions and finding allies. It's very difficult often because of time pressures. People feel like they're communicating effectively when they are not. One of the biggest questions, the most powerful question you have is the three letters, why? W-H-Y, why? Why are we doing this? Why are we not doing that? Help them to understand. Now, as the power of this question became apparent to me as a parent. When I was the hows and all those other things didn't become a problem for me. When my kids kept asking me why, it felt like they didn't trust me. And so, but the why makes you explain your rationale so they can understand what they might be missing. And so that they're now empowered. So you have to make it explicit to your provider that they're not doing a good job of explaining why they're saying what they're saying. It may make sense, but if they fully explain it, but it may not. So the power of the why are we doing this and why are we not doing that? And again, if they're intimidated by it, it becomes they're not confident in what they're saying, which again, find someone else. Because you should be able to say, I don't know the answers to that, but we will find it out together. And that's what you're looking for, someone who's in that battle with you.
I'm going to follow that out with a second question is, okay, so when should you get a second opinion from what is being recommended to you with regards to your care?
As simple as when you don't trust the first one. When you're being asked to do something that you think is extreme or beyond what you're willing to do, you want to seek a second opinion. Now, quite often, and hopefully most of the time, the second opinion is only going to affirm what you thought was going to happen to begin, what you were initially told. Because we're practicing standard of care, meaning what we know the evidence says works, everybody should be telling you the same thing. Now, everyone gets caught up in thinking about themselves as a unique individual, and you truly are a unique individual. The disease processes, however, are repeat themselves. And so it may manifest differently in you, but it's the same thing. And so coming to grips with that is often difficult for people to hear and to deal with. But that's a process, again, that when you've got a provider that you are comfortable with and that understands where you're at in that journey. They help you walk your way through it, through the fear of those treatment decisions you're concerned about. Because let's be honest, that's when you're going to be asking for a second opinion. When you're asking me to do something that scares me, I want to hear it from somebody else before I'll do it. And so you need someone that you trust at that point that can help you through that process. That's my words.
And just to echo what has already been said, you are your best advocate. As was stated before, for a spouse, you need to get his or her permission as to whether or not they want you to attend that appointment with them, and ask questions. Do your homework before you get there. Have your questions prepared. I'm a firm believer, no question is a dumb question. And as was stated before, if they tend to get impatient with you, don't want to answer your questions, then it's time to look for another provider. I can't tell you the number of times when I was practicing in retail, I would have a patient come in with a prescription, getting it filled, and not knowing what it is and what it's for. So in pharmacy school, we're taught to ask open-ended questions so we can get an answer, so we can start a dialogue, so we can start a conversation, because we want you to understand what you're taking, why you're taking it, and kind of what to expect from it. So you have to pay attention to yourself. Know yourself. And the best thing you can do before your appointment is write down your questions. Go in and ask your questions. If you're not getting the answers that you want, then perhaps it is time to look for someone else.
I was just going to add that as a gynecologist, many people seek me out for a second opinion. For someone said, recommended X, Y, and Z for them, and they want to make sure that they feel comfortable about it. I'm never offended when I receive the consult, and I'm never offended when someone says, well, I'm not necessarily sure about what you're recommending. I'm going to go ask someone else. Now, I will tell you, I do get a little offended if you go ask Google, because I wear like this badge that says physician, that says that I know more than Google. Okay, and so I'm like, ask me the question. Ask me why. Why am I suggesting this? Why am I suggesting that? I think it's wonderful when someone brings their support person in. I think it's wonderful when people write down their questions and they ask their questions and so forth. And honestly, I think it's even nice when they bring their Google questions in. But I don't like when they go ask Google after I done told them. But I think it's good for them to come with all their questions and so forth like that. It is very important for you to be an advocate for yourself. It's very important for you to be an advocate for your family members. However, the hallmark trait between a relationship between a physician and a patient is trust. And if you do not trust the person that is caring for you, then I encourage you to find another provider. So we had another question, and I kind of wanted to go back to the COVID stuff. And it says, I did get 3 COVID shots. In November, she's turning 60. However, she never had a flu shot. She has never got the flu over the years. Should she start getting the flu shot? And does she need to get more COVID shots?
Yes.
I don't know, just in my everyday life, I have people say to me, well, I've never gotten the flu. I've never gotten the flu shot. I don't get the flu shot because it makes me sick. And sometimes I engage in those conversations and sometimes I don't. Because you've never gotten the flu does not mean you won't get it. And yes, getting the flu shot oftentimes make you feel like you have flu symptoms. The runny nose, the headache, the feeling bad, but that's kind of all process how your body is handling that shot at that time. So, especially if you're over 60 and you have chronic diseases, you need to get the flu shot. There are required pneumonia shots that you have to get when you turn 65. I hope you have gotten those if you're 65 and older. As far as COVID, the new the new strain is available now, get it. Because COVID is not gone. It's still here. There's still people that are dying from COVID. There's still people that are getting COVID, but because they have been vaccinated, the symptoms are less. They're not sick as long, and they get it and they keep moving. But then, as someone spoke about earlier, there's the long haul COVID, and there's still a lot of people walking around here suffering from long haul COVID, and it's not a joke. Respiratory problems, brain fogginess, memory loss, is there, even heart problems. So it's kind of like I got a touch of sugar. You don't have a touch of sugar, you're diabetic. It's kind of like, the doctor says my blood pressure is up, but I feel fine. If your doctor says your blood pressure is up, it's up. They're silent, they call them silent killers, and they're not silent for no reason.
I wanted to pause for a second and introduce Dr. Clark, because I wanted him to introduce himself real quickly, because I do have like 2 or 3 questions for him too.
Hi, good morning, everyone. I hope you can hear me. First of all, I wanted to say a big sorry for keeping you waiting. I was called into the hospital this morning, and because you've been waiting, I'm more than happy to stay a little longer to answer any GI-related questions as well. One last line on the flu vaccines that they're talking about. The 2 simple answers are yes and yes. And here's why. Flu vaccines don't stop you from getting the flu, but your severity of illness and what happens to you down the line is significantly reduced. So some people say to us, I got the vaccine last year and I still got the flu. Well, it wasn't supposed to stop you from getting the flu, and you may have had a much more severe illness. Again, thank you for joining us this morning, and I'm sorry to have joined you late, but when you get a call on this thing in here, sometimes you don't have an option. Thanks again.
All right, we have another question.
I have a girlfriend who had contracted COVID 3 times. And this last time, which was the beginning of the month when we had our class reunion, half of the class caught COVID, excuse me, the other half caught upper respiratory. When my girlfriend went back to the doctor to be checked after she took the medication for the 5 days, she said he didn't have to test her again, that she was cured from it. Is that true or false?
Correct. According to CDC guidelines, you don't retest anymore. The idea of the test staying positive after you've been cured, early on, they found this out. It can stay positive longer than you have symptoms and longer than you're shedding. And so they're still trying to figure out exactly what that data means. And so after you've gone through the 5 or 10 day, depending on the level of symptoms, 5 days from the last symptoms, you're considered clear.
Thank you.
All right, we have another question.
What was the website that you mentioned earlier?
RWJF, Robert Wood Johnson Foundation.org. And it's you'll look for the zip codes link. Zip codes, RWJF.org.
We had some GI questions. The question was, I had surgery for stomach cancer approximately 5 years ago. And then it's a combo question because 2 people asked the same question. Essentially, what is healthy diets and healthy practices to prevent stomach and colon cancer?
So thank you for bringing that up. To the individual who had the surgery, our best wishes for you as you go through this. I typically don't like to comment about surgeries unless we have more specifics. So what you think is stomach surgery might just be in the top of the stomach, involve the small intestine as well. But the key thing to do here is to keep your follow-up as was recommended after your surgery, just to make sure if you need additional treatment, you get it, or to make sure the disease is not coming back, whatever cancer it was. It is also vital then to speak to the doctors that if it was in other parts of your bowel, whether you have a genetic risk factor, so other members of your family can be screened. In 2024, and we've had this for many years now, a simple blood test can be run, which will give you a spectrum of genes that puts people at risk. And then also, it's very helpful that even though we generally don't like to talk about our health at the barbecue and everything else, hiding some of these things from close family members may reduce the chances of others getting screened, okay? So I'm happy to sidebar the individual and share some thoughts when I have some more details. Regarding what is considered as a healthy diet, I think a good mix of protein, carbohydrates, and fat. Now, what am I talking about? Common sense, okay? All of us enjoy a good steak once in a while. There's nothing wrong with eating steak if we don't overdo it. I'll tell you a brief story. I know a French baker who had a lovely bakery, and every time I showed up, I would complain, and I'll still buy half a dozen croissants. So one day he said to me, would you stop moaning? The fact that you buy them doesn't mean you have to eat them, okay? So what can we do to prevent large bowel malignancies, for instance? Diets which are excessive in meats, high calorie dense things, may have a small risk factor in helping you to reduce that. People talk about certain specific foods, going to the spa, having a washout. Unfortunately, it makes you feel better. Your bowels are cleaned out. You are in a nice environment that smells good. There's good music in the background, but doesn't do anything for you at all. If there is one thing to take away from all of this, talk to your primary care doctor when you turn 45 and get screened. If you don't want a colonoscopy, that's okay. There are different ways of screening for that as well, provided you don't have a family history of malignancies. So start the conversation by saying, hey, I just turned 45. How about getting my screening done? And if they ask you to go for a colonoscopy and you have reservations, don't take the referral and leave it on the fridge. Ask them, do I have other options? Okay, so those are the things to think about. Unfortunately, we tend to see that happening much more in an advanced stage in people like us. And the reason why mostly that happens is we don't get screened. We wait very long until we have symptoms. There is a myth that it tends to affect us much worse. There was a very good study done in California that if everybody is screened at the right age, our chances of survival are just as good. So start the conversation when you turn 45. You don't have to tell anyone what your age is, but at least start the conversation. Thank you.
I'll just add to say that as a gynecologist, when my ladies come to see me and they are knocking on the door of 40, I start having the conversation with them because I am going to refer to them to get a colonoscopy at age 45. I had a patient who was a friend and happened to be a sorority sister, and I said, hey, you're 45, the recommendations are for you to have a colonoscopy and whatever. She doesn't push back. She doesn't have any symptoms or anything like that. She gets a colonoscopy and she has an asymptomatic, so she's not symptomatic, she's not having any bleeding, she's not having any pain, but she has this large mass in her colon that she ended up having removed and losing a portion of her colon, but she had no symptoms, and that was all found because she was screened. So I, as a gynecologist, recommend getting colonoscopies too.
I recently had a colonoscopy, and there was I had H. pylori. I think, am I saying that right? How does that happen, and how do you prevent it from happening again?
So I think there's a slight mix-up in here. The H. pylori infection is found on the upper scope, not on the lower scope. Okay, so you probably had both. I don't know the details. But typically, we don't test for H. pylori on colonoscopy because that's not where it lives. So how do you get H. pylori? It's all dependent on the environment that we grew up in. If you grew up in crowded spaces and people have the infection, then your chances are slightly higher. If we also grew up in environments where perhaps we didn't have as many resources as everybody else, that's the chances that increase for you to get H. pylori. Think about it this way. It's an infection that you can get rid of with antibiotics and acid-reducing medicines. And after you've taken the medicines, go back after a month, going back to what we talked about, and get screened again. You don't need another colonoscopy. You need a stool test which will tell you that it's gone away. Why do we care? Your risk of cancer goes up. If you leave it there, you don't do anything about it. Last thing I'm going to say, what stops any of us from taking antibiotics from a week and a half? Think of the risk and benefit.
I'm going to pause for a second and say, this morning when we started, when we started at 9:30, I said good morning, and you all said, good morning. I'm going to do it one more time. Good morning. Good morning. There you go. And so it is October, and October is Breast Cancer Awareness Month. Now, without me asking you all your age, because everybody in here looks 25, but I'm sure there are some mature women who are over the age of 40 in here, correct? That's me. I'm in there, okay? And so, of course, I definitely want to just make sure that we kind of really talk about Breast Cancer Awareness Month, and we talk about breast cancer. Dr. Screen is here, and I am an employee of UPMC, and UPMC is here. The Women's Health Service Line is here. And if you need to get a mammogram scheduled, or if you need information about mammograms and stuff like that, I am going to encourage you all to get it done. It takes 7 minutes to get done. And I definitely have a question about mammograms too, and breast cancer. But I want to make sure that we all know that October is Breast Cancer Awareness Month.
Good morning. Difficulty swallowing dense breads and meat and large pills. Is it part of aging with the esophagus? Do I need an EGD?
So thank you.
I'm getting nervous.
Thank you for bringing that up. Difficulty swallowing is never normal. So if that happens to you, you need to get further evaluations, okay? There are many reasons why that happened, and it could start from something as simple as acid reflux, all the way to a malignancy, a growth, something that's narrowing that area. And the only way we can tell which one it is to get seen by somebody and referred for an upper endoscopy, and there are other tests that we do to help make the diagnosis as well. The key thing to think, like everyone is saying, be your own advocate. I don't feel right. I have difficulty swallowing. Don't let anyone tell you it's because you are older or it's in your head.
Good morning. Good morning. My question is, if you have severe pain in your lower left part of your belly.
Do it again. There you go.
If you have pain in your lower left belly and you go to the emergency room, how do we know whether they just said it was constipation, but how do we know it's not a female problem?
I missed the last part of what is it.
How do we know it's not a female problem?
It's not a female problem. So I think you have the two people in here, the GI side and the female side as well. Again, there are so many things that can give you pain on that side that it would be unfortunate if I were to just say it's these things that is doing that. Ask the real things that you don't get answered in the emergency room. And also think about it this way. And this might not make me any friends in here, but I'm going to be very honest. Why are you waiting to be so bad to get to the emergency room? Okay? and this is not a knock on anyone, I'm just as bad as you. Sometimes I need to see my doctor, I miss it for a few days, and then I tell myself I should know better. But be it as may, when you show up in the emergency room is not set up to be doing a thorough evaluation. They just want to get you in, out, and you go in there. So let's start off by keeping your annual visits. When you start having symptoms, you call the doctor's office, make an appointment, instead of getting very bad to get to when you get to the emergency room. It is only when you are evaluated that we can tell whether it's a female problem or it's a GI issue. My colleagues may have something to say about that as well.
I agree that when patients go to the emergency room, often it's kind of like, is it urgent or is it not urgent? And I feel like there's times where they're just like, oh, you're not urgent, so follow up with somebody as an outpatient. And it might not be girl, it might be GI, but it might not be GI, it might be girl. And often those symptoms kind of, they mimic one another. And the way that we often figure it out is 1, what's your history, 2, physical exam, sometimes 3, imaging, and when all else fails, sometimes you end up getting a procedure because that's how we rule it out. But if you are having a problem that is kind of abdominal pelvic, the only way that we're going to really be able to tell is by if you are fully evaluated.
And I just want to chime in there. One of the things that you've heard already is the going to the appropriate place at the appropriate time. We recently opened a site in Steelton, for those of you who don't know, for the same reason. We want primary care, not urgent care, not emergency care. And the idea is that if we get you earlier, we can get things at an earlier stage before they become a significant problem. When you go into the emergency room, their evaluation and management, they're going to make sure that you're not acutely dying. That's really what they're worried about at the moment. The rest of it becomes, there's time to figure this out, which is what you want the reassurance of, but that follow-up and that follow-through are the critical things to make sure that we do run to ground what the actual issue is and have it managed.
We have another question.
Can you talk about the disparity of healthcare in the African American community? And I'll tell you an example of that. I went to have a heart cath, and they couldn't find a vein to numb me. They said, oh, well, when you get back there with the doctor, while you're under, he'll numb you. Well, I wasn't even really back there long enough before he came in and said, okay, lay still. And then he injected me once, and 2 seconds later, he injected me with the dye. Now, I know that first injection did not have a chance to numb me. And when I went back and complained to him, he sort of poo-pooed me, thinking that I didn't know what I was talking about. In that case, where do you go complain?
All of these hospital systems now use what's called Press Ganey. You will get a survey, whether that's email or paper, fill it out. They watch those, they listen to those. There are also, and now I'm drawing a blank on advocates within the hospital that you can communicate with that will speak on your behalf and address that issue.
So we're talking about, you start talking about disparities. You're talking about a patient experience. You're talking about healthcare outcomes that Robert Wood Johnson talks about, the difference in life expectancy. What you're talking about now is just the way you treated me and the respect or lack of respect you provided me. And as you've heard, there are 2 system-wide responses. The third thing you want to know is that now the government, depending on what happens in a month, is going to be moving forward on these new measures where they actually measure what's happening with patient experience. So they're going to look across demographic groups and saying, are you treating African Americans differently? Are you treating Hispanics differently? Because they want to know real-time feedback. Is everyone getting the same level of quality of care? So these things where they, as you said, were poo-pooed before, and there are, let's be honest, old guard people that are still going to have to be washed out of the system itself has to respond. And so using these avenues you have to bring forward these issues is crucial.
I know that most health systems they have a patient relations, and that information is shared often with the physician, and from being shared not only with the physician, it's shared with the medical executive committee or the administrators within the hospital if patients are having a poor experience. If you have a poor experience, I encourage you to share that you're having a poor experience, because it might just not be you. It might also be somebody else. And if there is a trend that a certain person is performing below the expected or performing not kind or whatever, we never know unless you actually report it. So you're not telling on anybody. Things don't get better if you don't say anything. And there is the Press Ganey score that every physician receives. I think I get mine, if not once a month, every quarter, something like that. So I know what people say about me, and it does matter. I think it's really, really, really important.
I also just wanted to add regarding health disparities. We see those in female, especially obstetric care. There is maternal mortality, which is significantly higher. And regarding breast cancer, there is a difference in the breast cancer that African American women often are diagnosed with versus Caucasian women. That's usually triple negative breast cancer. It tends to be more aggressive, and it's seen at a younger age in us. So there have been some things like talking about getting earlier mammograms in women, close follow-up with your primary care provider. There is a difference. For breast cancer, it's always early detection.
So just like everyone has mentioned, in addition to the hospitals receiving these things, the individual physician's supervisor or their boss also gets to review them. And so it's very helpful to send these things coming in and be very objective about what happened, why it happened, and how you felt. So it allows the review to be done thoroughly.
We had another question with regards to breast. The question was, are there any studies or technological developments to better diagnose those with dense breast tissues? So we know that the standard is a mammogram. However, is there any recommendation for anything outside of mammogram for a woman who has dense breast tissue?
So there are a couple of things. About 50% of women have dense breast tissue. That does, independent of anything else, slightly increase your risk of developing breast cancer. But also it can lead to missed cancer. So what do I do? You want to go to an accredited facility. Most of the hospital systems, UPMC, Hershey, Geisinger, they usually have accredited programs. So that's your first step. You want to know that the equipment is up to par and the people performing the mammograms and reading them have also met that standard. There are some newer technologies within mammogram. You may have heard of 3D mammograms. It's essentially like a CAT scan of the breast. So it goes layer by layer, and it can uncover things that you wouldn't normally see in a 2D mammogram in a dense breast. Throughout the country now, though, we now have a law that says if a woman is found to have dense breast, you must inform her of that and let her know that she is entitled to additional imaging as I stated, higher miss rate and increased risk of breast cancer. The other two modalities would be ultrasound and breast MRI. You need other risk factors in order for your insurance typically to cover breast MRI. Your risk needs to be over 20%. Breast density can be factored into that, but you can't just go out and ask for a breast MRI. It's time consuming, it's costly. You don't want to end up with a bill. I'm not discouraging that. I'm just saying talk to your healthcare provider and see if that's an appropriate test for you. The other option is typically ultrasound. It's not around a lot. Probably one of the best modalities is automated whole breast ultrasound. That's a newer technology that hopefully we will see more of. And then you can do whole breast ultrasound done by a person. There is some variability, and the difficulty with ultrasound sometimes is it depends on the skill level and the interest level of the person doing it. I think the most important thing is, though, you don't rely on any one modality. Mammograms are an excellent test. They pick up 90% of all mammograms, but they're not 100%. You absolutely, whether you have dense breast or not, want to perform your breast self-exam monthly and see your healthcare provider, your PCP, your gynecologist, your breast surgeon if you're at high risk for an annual breast exam. In addition, if you feel something, find something, have a question, seek out answers to those questions. But the other modalities are make sure your facility is doing 3D mammograms, and then ask if you are a candidate for either whole breast ultrasound or breast MRI.
And I just want to add one part. The crucial word that was stated in there is a law requiring additional screening being mandated. Think of this upcoming election in terms of your health care. What is required, what's available, and who's going to suffer if things change. I work for a federally funded organization, so I am not advocating for any particular view. I am sharing information for you to consider as you're making your decisions and making sure that you engage those people you know who may not be as actively participating in this process as they need to be to shape what happens in your community, our country.
I wanted to follow up with a question. I think many people are familiar with mammograms and how mammograms are done, and I think there's a lot of thought of, oh, I don't want to get my breast squeezed, and oh my God, this hurts, and so forth like that. However, I don't really think a lot of people know how breast MRIs are done, and I think there's a lot of times people are like, I don't want to get this mammogram, I'm just going to get a breast MRI, and they don't know how a breast MRI is done. And so, can you talk a little bit how about breast MRIs are done?
I can go a little off topic. Can you raise your hand if you have children? They don't want their shots. Do you take them anyway? I'm just saying, okay. Breast MRIs are not fun. None of it is fun, but is it detrimental? Is it miserable? Is it horrible? Is it awful? No. You go and you get it taken care of. You have a little bit of discomfort for a short amount of time. Breast MRIs take 30 to 45 minutes. They require an IV. So I know some of you may have had breast MRI of a knee and you just go get in the tube in 15 minutes, you're out. No, you need an IV. You have to lay on your stomach. So if you're not comfortable laying on your stomach for 30 to 45 minutes, you can add that in. There's also, it's called a breast coil, which your breast lay in, and it has a panel that lays right up against your breastbone. And about 5 minutes in, that starts to get real uncomfortable, and that's when the tech says, now don't move or we'll have to start over. Also, it's not cheap. It's time consuming. It is a great test for the appropriate person, and you want to find out if you're the appropriate person, but it's not a solution. Not to mention, there are things that are detected on mammogram that are not going to be detected on breast MRI. One does not substitute for the other. They complement each other. And we can do this. We're all big girls.
So one of the things that, of course, I want to make sure that we also chat about before we end this Ask the Doctor is, of course, your preventative care. And as it has been mentioned and discussed multiple times, that it's important for you to have your relationship with a physician, and that will often most likely keep you out of the emergency room if you have all of that. And of course, if you're a woman, you want to get your mammogram. We also talked about the colonoscopy. Of course, I'm going to encourage you to see your gynecologist. And one of the questions that I always get is, well, if I'm not sexually active, do I need to come and see you? Yes, you do. You should come and see me. Well, do I need a pap smear? Do I not need a pap smear? And that is a loaded question and so forth. Many of us have young relatives that need to see me, and one of the questions that is always asked, when should I bring my family member to see a gynecologist? I like to see them when they're teenagers. I like to see them before they're sexually active and so forth like that, for multiple different reasons. And of course, I want to encourage everybody to start getting pap smears at age 21, because that is the standard and the recommendation of care. And so I don't know if we have anybody that can really speak to for screening for men about prostate cancer and so forth like that.
Again, prostate cancer screening is one of those things that you'll hear, again, politically bandied about, and about who suffers most from it when it becomes an issue. And so the simple answer is Black men need to be screened earlier and more frequently than white men. We get earlier disease, we get more severe disease, and we die of the disease, whereas they die with the disease. And so that's why you will hear these things happening. So you start having this conversation when you're approximately 40. 40 is when you want to start having it. If you're having any symptoms or have any family history, you start worrying about, you start earlier. Again, it starts with the discussion of, are you having any symptoms? How high a risk are you as an individual? And what else do we want to look at as we're moving forward? And so, again, it's another one of those things of people needing to overcome a short-term fear about a procedure and trust in order to have long-term benefits to their health. Again, will ideally most screenings be negative? Yes, but those that you find that are positive, you have a significant impact on, and that's what we're trying to find.
So if I may add one line, very well said. One of the things we hear sometimes is, oh, doctor, since you're doing my colonoscopy, could you just check it out for me? No. The gastroenterologist test that he's doing is not designed to do that. Second thing that we misunderstand is, oh, if it gets done and they find something, they're going to stick a needle in there and do a biopsy. Again, it all starts with a conversation. There's an MRI of your prostate that can be done. There's a scoring system. So the vast majority of people would not have to go through that biopsy. So in essence, what we are all saying is, don't let your fear or your concern stop you from discussing it to start with, and then choosing your options.
We have two more questions before we end this segment.
Dr. Lynch, can I just add to that? I know we've talked about mammograms, but real quick, because there's a lot of confusion about when to start your screening mammograms, that should begin at age 40, and it should be every year after that up until about 70. When your life expectancy is less than about 10 years, then you can stop mammogram screening. And women who have a family history or are at high risk for developing breast cancer should begin screening 10 years before their youngest relative was diagnosed.
Yes, my question is a GI question, and also maybe better how to deal with the system when your knowledge base about medicine and physicians has been one that's been fear-based by your parents or their parents, which thought if you go to a physician, you know, they're going to cut on you or they're going to find something wrong. So I have a loved one who's in town for a week, but they've lost well over 120 pounds. They've been going to walk-in centers, or what do you call those, walk-in clinics or whatever, the walk-in centers, and where they can have control. So women, you guys do much better than we men do at this kind of thing. Men want to go, a lot of men want to go into a situation where they can be in control. And I have a loved one who's like that, but he's not doing well. And I got calls from different family members while he's in town. I got to try and figure out how to get him into an actual GI physician. He was told at the walk-in clinic he's got H. pylori. He was given something, but which he's not been taken. He's just losing weight and suffering from two different things: constipation and diarrhea, can't hold food down, constantly nauseous. So I'd love feedback on a way to do it that's legal to get him in there. I don't want to knock him out or drug him, so I'd like some good feedback on that.
So you started off with something which is very relevant, and we should never dismiss that. The historical fear and distrust of the system. It is real, okay? And we can't get over that. I think what we are all saying is, we should then start thinking of, are we going to be at a disadvantage because of that fear and concern? Okay, so that's a separate conversation. So what you're asking is, how do we start the conversation of getting these individuals to see somebody and be evaluated? I can tell you right off the bat, without knowing any history, that H. pylori should not lead to him or her losing this amount of weight and having all those symptoms. Sometimes it starts with a very honest conversation from people they respect, they trust, or who've been through something similar, okay? So if you have other friends, other family members who've been unwell and have had some good experiences with the healthcare system, having them speak to them, and then you as the person they rely on, that everyone is giving you a call, closing the door and asking very straightforward things. I love what my colleagues were saying in here. We all have children. Sometimes they don't want to go to bed. Sometimes they don't want to go to school. Sometimes they don't want to do other things. Children grow to become adults and we keep the same habits. True? So having those conversations with him. And the last thing I say is sometimes finding out which kind of doctor or healthcare provider they will feel comfortable with. So the person might not have an OBGYN issue, but then they look and say, I feel very comfortable with this doctor because people have said good things about them. Go and have a conversation with them, okay? The person may not have a GI issue, they may have a cardiology issue, and they may feel more comfortable if I say to them, go and see Dr. Jones or Dr. Smith. Yes, we practice in specialties, but we're not in silos. Well, I shouldn't say that. Sometimes we are in silos, exactly. But we're happy to go the extra mile to give you some reassurance, to say, go and see somebody else, have that conversation with them. So the last line is, you may have to smack him around. I'm kidding. No. Let's have honest conversations amongst ourselves, okay? Because sometimes we become our own worst enemies when we are not willing to have these conversations. He or she might be mad at you for a few weeks, but you've done the right thing.
And this is our last question.
Yes, I hear a lot of information on breast cancer with women. Can someone give me some information on breast cancer with men?
So men do get breast cancer. 100 women who get breast cancer, 1 man will be diagnosed. It's usually diagnosed at a later stage because we're not looking for it. Doing breast self-exam is certainly reasonable. Awareness is another thing. Ignoring findings are something that you cannot do, and when you notice something and it persists for more than a week, you need to tell somebody, whether that's your spouse, your healthcare provider, and you need to get it looked into. And yes, men do get mammograms, men do get breast cancer. It's treated very similar to how we treat women with breast cancer. The biggest difference is surgically, typically men get mastectomies. We don't do lumpectomies on men.
So I would just like to thank my colleagues for a wonderful panel, and hopefully we will see you all again next year here at the second Saturday of October, which is October 11th. If you all will please give me one more second so we can give you instructions with regards to the rest of the afternoon.
So let's give it up again for this panel, because I need them to come back next year. So can we do it a little bit louder so that when I send them an email and say, will you, they will say yes. And thank you so very much. So for those of you who have the reward card, the 2 people, raise your hand to my left, the 2 people to the right, they will punch your card. And if you have to visit other exhibitors, please do so. But once you're finished, your $50 Giant gift card is waiting for you. We do have other presentations. We have yoga and Afro cardio going on in the auditorium, so please don't leave. If you have not had a chance to spin the wheel for a prize, please do that as well. And again, thank you so very much, and we will see you this time next year, right?
To answer more questions.
Dr. Clark is willing to stay to answer any more questions if you want to have some questions directly with him, and probably the other panelists as well. Thank you.